more fun stuff. Let's go to adrenals, yeah?
Yes.
Okay. So imagine you get a patient who comes and looks like this. In the clinical STEM, they give you a patient that looks like this. What is your spot diagnosis?
Beauregard.
Huh?
The blueberry girl from Willy Wonka.
Oh my god.
Cushing's syndrome. Syndrome, right? So when you suspect somebody of having Cushing's syndrome, typically you're going to have what? Central obesity, thin limbs, abdominal striae, easy bruising, hypertension, hyperglycemia. And the problem where somebody is having Cushing's syndrome is because they have too much what? Cortisol. That is the problem, right? Okay, now when you think about Cushing's syndrome, you suspect it, right? Suspicion alone is great, but you got to prove something. So what are you going to do in order for you to diagnose your suspicion? Huh? Okay, so number 1, 2, and 3. There's 3 potential tests that you can actually do. What is the first test you can do?
8 a.m. cortisol. Oh, are we not on
24-hour cortisol. Urine cortisol.
24-hour
That's stimulation.
urine cortisol. Great. What else?
ECTH stimulation.
The DEXA.
Mm-mm. Yes, low dose dexamethasone, low dose dexa suppression test, and last is late night salivary
cortisol.
salivary
I said 8
cortisol.
Yes.
Okay, so the 3 tests that exist when you suspect Cushing's syndrome is pretty straightforward, actually not difficult. Okay, once you learn it properly, you'll remember it forever. It's only 3 things. Late night salivary cortisol. What you do is at night for the patient at 11 p.m. Not 10, not 12, 11 p.m. Okay, I don't know why Endocrinology Society likes 11 p.m. so much, but 11 p.m. you check their salivary cortisol. The patients go home, they get their salivary cortisol, they send it out, and they'll check what the cortisol levels are. Typically, cortisol tends to have a diurnal variation, so you expect the late night salivary cortisol to actually be low. Okay, and that is basically how you've proven that the patient's got too much cortisol. Great. Once you've gotten to this point and said, okay, I did one of my 3 tests and I've proven that the patient's got too much cortisol, what's your next step?
High-dose dexamethasone or ACTH.
Okay, so when you think about Cushing syndrome, right, you can either be producing too much cortisol from your adrenal gland or you could be producing too much ACTH, right? Now the ACTH typically is produced in the pituitary gland. Anterior pituitary gland is what ACTH is produced. But some cancers can also produce ACTH. So the rightful thing to do next here would be to get ACTH. Why do I say that? Because if your adrenal gland was producing cortisol, what is that going to do to ACTH? Suppress it because it's giving negative feedback. So just by getting ACTH level, and if the ACTH level is low, that already tells you it's the adrenal. But if the ACTH level is high, now it could be pituitary or cancer, right? So if your ACTH level is going to be low, what's your next step? You're saying it's most likely the adrenal gland. So what are you going to do? CT abdomen. The simple rule of thumb when it comes to endocrinology, labs first, image after. You got a problem with it, remove it. Right? That's endocrinology. Lab first, image later. Got a problem with it, remove it. Deal? So here, lab first, ACTH is suppressed, right? Meaning the problem's in the adrenal. Get a CT of the abdomen, you see an adrenal tumor that's producing too much cortisol. What are you going to do? Remove it. Squamous cell produces PTH-related peptide,
Yeah.
We get SIADH.
I said-
right? Small cell lung cancer produces ACTH, SIADH, and what else the third thing it causes?
Lambert-Eaton.
Lambert-Eaton syndrome. So your pituitary gland, which is part of your normal axis, right? Your normal negative feedback loop exists with your ACTH coming from pituitary. But does the lung, which is producing ACTH, under the normal suppression? No. So you giving high dose dexamethasone, will it suppress your lung? No, it will not suppress your lung. Will it suppress pituitary? It will. So if it suppresses, then it's your pituitary gland, get a head MRI, right? If it does not suppress, it's most likely your lung, get a lung CT, right? How do you treat both of them? Remove it. If there's a tumor, go for surgery. That's your Cushing syndrome straight off the bat, and there's nothing more to do about it. Okay?
What's that?
As long as you remember for your initial screening, it's these three. Okay? Prove that you got too much cortisol. Next, go to ACTH. Then do your high dose dexamethasone suppression test. Biochemistry first, imaging later, remove it. Imagine we didn't know much about Cushing syndrome. Okay? And we did the test to diagnose Cushing syndrome, and we assumed the patient had adrenal tumor, right, is what we thought, and you removed it falsely. But truly what the patient had was a pituitary adenoma. What would happen if you had an adrenal tumor that's producing too much cortisol, okay, but you suspected it was that? Say you removed it, okay, you're taking away the negative feedback on the pituitary gland. So moment you remove your adrenal gland falsely, if there actually was a true pituitary adenoma that was actually causing Cushing syndrome, that's going to become much bigger and cause problems. Once patients got Cushing syndrome and you found out that the patient's Cushing syndrome is because of a right adrenal tumor and you remove the right adrenal gland, right after you remove it, are you going to put this patient on steroids? After how long of being on steroids does it become a problem? Thank you for watching. If you like our content, please like this video, subscribe to our channel, and hit the bell icon so you get notified when a video is released every week. Have fun studying. We'll see you on the next one.